Welcome to our Geneve webinar for December. We've been doing these about every month on different topics. Just gives us a chance to have a little chat about different topics, areas of interest. Usually what happens is we have a topic set for the day and we'll mostly cover that, but other things often come up and that's fine. I am Rebecca Dunsmore-Sue. I am an OBGYN, board certified, who lives in Seattle, Washington, and practices here. I'm also what's called a NAMS certified menopause practitioner, which means I did a little extra work and took an extra test to become someone who's expert in menopause. And I practice full spectrum OBGYN, although my clinic focuses on menopause specifically and sexual health and vaginal health particularly. So that's how I come to this. And I've been working with Geneve for over a year now, both with content and helping as their director of health to make sure that the information we provide on our website is valid and verified and medically accurate. As well as, we like to bring alternative type therapies to the website, but make sure that they're not going to be harmful. Well, now that we've waited a few minutes for people to come in, I am going to sort of start in with a couple of questions that we had come up ahead of time. I don't know if those folks are on yet, but even if they're not on, they can always watch the recording later on. They're not specifically about testosterone, so I'm just going to briefly go through each of the questions, and then we'll move on to the testosterone and sexual function part of the evening. The first question that came in was about the foggy-headedness and word retrieval problems that come with menopause. And is that normal, and what does that do to? So number one, yes, it's very normal. A lot of women feel that fogginess start up with menopause. It's probably the most dramatic in the perimenopause and then eases a bit into the regular menopause for most women. There are several explanations for it. And the most commonly used are that, one, estrogen has actually a very important role in the brain, which it does. We know there are estrogen receptors in the brain. And so there's probably some interaction with the dropping estrogen and brain function. The second is that estrogen's involved in what we call the serotonergic system. So it's the system that also affects mood. So everyone's heard of the serotonin reuptake inhibitors, or SSRIs. That are antidepressants. Well, estrogen and serotonin react in the brain. And so that can also cause some foggy-headedness as well as some depression. And that tends to be mostly in the perimenopause, that the depression and mood issues are the worst, and then those ease off, and some of the foggy-headedness tends to go away with that. But women can experience some level of sort of decreased word recall even through into regular menopause. And I often recommend, first of all, just word games, crosswords, activity and socialization. Those are very helpful. And then some women actually consider hormone therapy for that. The second question was relating to periodic shooting pains in the arms and legs. That is not a common symptom of menopause. That's generally a symptom due to something else. It can be due to a neurologic disorder or a neuropathy. It can be simply a pinched nerve. So that's definitely something to go see your primary care doctor about, because it's not menopause causing that particular one. And it's something to at least have evaluated with your primary care doctor. All right, now that we answered a few questions, I'm going to move on to the sexual function portion and the testosterone and DHEA portion of this evening. So when I discuss this topic, I usually like to start by talking with women about what is normal sexual function, both pre- and postmenopausally. And the answer is it is variable for all people. I think we are encouraged by the media around us to believe that everyone is having a lot more sex than we are. And that in all reality, if you actually look at postmenopausal women, and they've done surveys of this, 20 to 30% of them are having sex less than once a month. That's normal for them. The next largest group, about 30 to 40% are having sex maybe 2 times a month. So we should never judge ourselves by the media. What is normal for us is what is normal for us. And the important part of that is that normal sexual function is sexual function at a level that does not cause you distress. It is not considered hypoactive sexual desire disorder unless you are distressed by your lack of desire. You want to have more sex. If you are comfortable with the amount of intercourse you are having, even if your partner is uncomfortable, That is not hypoactive sexual desire disorder. That just means you're mismatched and you need counseling for that. So I think those are very important definitions to start off with, because a lot of studies that look at medications focus on hypoactive sexual desire disorder. So they focus on how do we increase desire in women who want to increase desire. And the group that you start with when you do a study makes a lot of difference into how your study comes out. And we'll talk a little more about that later. So when we look at studies of hypoactive sexual desire disorder, we also have to assess whether they're looking at pre or postmenopausal women in those studies. So a lot of people have heard about ADI, which is a sexual desire drug for women. That was tested only in premenopausal women. And really, we don't know what its impact would be on postmenopausal women. That would be an off-label use of the drug. And so I tend not to recommend it for that, among other reasons. I didn't think the studies were particularly good. I didn't think it increased sexual function particularly well. And it has a lot of side effects. So it's not a drug I particularly use, mostly because my patients are menopausal, and I don't have any data about whether it'll work for them or be safe for them. What has been studied for this in menopause is both testosterone in conjunction with hormone therapy like estrogen, progesterone, and DHEA, which is, I'm going to say this wrong, but I'm going to try to do it right. I actually have it written out over here because I always pronounce it wrong. Dehydroepiandrosterone. Hold on, I see I said it wrong. Dehydroepiandrosterone. Which is basically a precursor hormone to both estrogen and progesterone. But it's most oftenly referred to as DHEA for obvious reasons. So these two the hormone and the precursor hormone, so T and DHEA, have both been looked at for this. They have both been looked at in series of very small studies, which is frustrating as a researcher because it means that I know that we need one big study, wherever it is randomized, to really tell us more information. But there are ways that we can take a series of smaller studies and bring them together to help us to understand what they're telling us. And that's been done for both of these medications. For those of us in the medical field, it's called the Cochrane review. So basically there's a group at the Cochrane Library that actually takes every study published on a subject, grades them by quality, puts them all together and does what's called a meta-analysis, where it brings all the data together and makes results based on the larger pooled values. And so I'm going to start by talking about testosterone because there's far more research on that. There have been, I think, what did they say? 35 trials with almost 5,000 women on testosterone, either with or without estrogen. And overall, what those trials tell us, well, first of all, those trials are mostly at fairly low doses of testosterone. One of the issues we have in treating women with testosterone is we don't have great data on normal ranges for women, and normal ranges for women are actually quite wide. And women's testosterone drops over the course of their life, but doesn't drop a whole lot in menopause, actually. When estrogen does go down, testosterone stays fairly continuous. It drops slightly, but so does the protein that binds it in the blood. So the free testosterone level is about equivalent to what it was pre-menopause. That being said, it can vary over a very large range in any woman or in between women. The other thing to know about testosterone is if you have your ovaries removed, then you are very low in testosterone because testosterone is made by the ovaries. And even into menopause, it's made by the ovaries. So ovaries do have function in menopause for those who can keep them. So that was a sidetrack. So in these many, many studies, what they've looked at mostly is testosterone combined with estrogen and estrogen alone. So comparing those two, because they felt like one of the first interventions that might be made for low sexual desire is to try hormone therapy in postmenopausal women. And then they looked at hormone therapy versus hormone therapy plus testosterone. And what they found overall is that testosterone slightly increased sexual desire. Now, in all these studies, it only ever increased it slightly. And I think some of that is patient selection, and some of that is that I think the baselines may already have been fairly good. A few of the studies did what we consider a proper study in that they didn't rely on women being partnered. So they actually looked at even single women and their desire to masturbate and their desire to be sexual in some way. And even in those studies, it did increase desire to some degree. So I think that there is a role for testosterone in that sense, although I always warn women, we don't know well how to dose it. I tend to start very low when I use it. And there are side effects. And the side effects from testosterone are primarily what we call symptoms of androgenization or hirsutism. At low doses, the worst symptom tends to just be acne. At higher doses, if we give too much testosterone, we can do two main things. One is change your hair growth pattern. So both give you male pattern baldness on the head and male pattern beard growth on the face. And a lot of women as they age get this beard growth anyway, and that is actually a sign of androgen dominance because their ovaries are still making androgen. We all had grandmas who plucked those. The second thing you can do is lower a woman's voice. So testosterone at too high a level will lower your voice, such as it happens with boys in puberty. And if that change is made, it cannot be taken back. So you always need to be working with a provider who gives you testosterone who starts at a very low level. I got a question into the chat box. I'm going to address it before I move on with my next thought. And that was, do you start with the same dose for women without ovaries? The answer is yes, because most women who start on T, I tend to believe are women who have very low T to start with. So I'm always cautious with testosterone and start very low. And if it's doing nothing, then I might build it up slowly to a slightly higher dose. But I don't tend to go very high with it, because if it's not working even at lower doses, it's probably not going to do a whole lot of good. The other question I get a lot, which I haven't seen come up yet, but I'm going to preempt it, is testosterone safe in women who can't take estrogen? So women, say, who've had breast cancer. The answer is we don't know for sure. There are very, very small studies that have looked at testosterone in women and breast health that seem to indicate that testosterone may be anti-tumor growth for most people. That being said, we have very few studies in women with breast cancer. People just don't like to do them, and they don't like to do them with hormones. So I think that's a very deep and long discussion one would have with an oncologist. The other thing I want to mention is testosterone's role in the vaginal tissues. So for women with ovaries, you continue to make testosterone through menopause, and testosterone does have a positive effect on the vaginal tissues. It does premenopausally as well. But without estrogen, a lot of women still have symptoms. However, with women with ovaries, if it's purely vaginal issues that they're coming to me with, I don't add testosterone to the vaginal tissues for that. Women who've had their ovaries removed, however, if they're having vaginal symptoms, I often recommend DHEA, which is the other medication I'm going to talk about, which turns into estrogen and testosterone in the vaginal tissues. And I think it's slightly more effective for those women than estrogen alone. So sometimes there's a role for that there. There have been some small studies of testosterone in terms of cardiovascular health or bone health. Testosterone and cardiovascular health is a tough one. There have been small studies that hint that it might be okay or not harmful for cardiovascular health. However, we do know that cholesterol parameters change when women start taking testosterone. So if a woman starts taking testosterone, then her HDL will fall, her good cholesterol, and her LDL or bad cholesterol will rise and look like a more male pattern. Those are what we call surrogate markers. That means, we can measure those and we can say, hey, these should be better. But those don't tell us if those cholesterols are then going into your carotid arteries or into your heart arteries and causing actual damage. There's a huge role of inflammation in the damage to the arteries as well as cholesterol. So slight adjustments in those things probably aren't that impactful, but we can't say for sure. So it's definitely something to think about. And women who have a very strong cardiovascular history in the family or themselves have one, I tend to stay away from testosterone for that reason. Before I move on to talking a little bit about DHEA, does anyone have any other questions about the testosterone arm of this? Well, you can always throw them at me later. I can answer them later too. So DHEA, as I said, is a precursor hormone. And in the body, DHEA is turned into testosterone, which is then turned into estrogen. And the way that happens is a series of enzymes, but the one you've probably heard of is the one that turns testosterone into estrogen, which is aromatase. The reason that's important is that when you make testosterone in menopause, it's actually circulating in your tissues, and a lot of tissues being turned into estrogen in very low levels. So that's one of the protective effects of keeping testosterone around in menopause. Women who have breast cancer who are on aromatase inhibitors get none of that, and so they tend to be much more severely affected with menopause because of that reason, because they really get zero exposure to estrogen because you take even the minimal exposure that they had from their fat cells and their ovaries away. So DHEA for many years has been thought to be a great way to get these precursor hormones into the female body and will turn into the right amount of testosterone or estrogen and will be great. So there have been good and bad studies on this, not nearly as many as we have on testosterone. And actually, when they did the Cochrane review on DHEA, because they did one for that too, what I found interesting is they found a lot of studies but had to get rid of a lot of them too. And the reason they had to get rid of a lot of them was because they weren't good enough to evaluate. And so they ended up in the end with 28 trials with only 1,273 women, but only 287 of those women had information that was what they considered high quality. So a lot less good information. The other thing to know about DHEA is it really is important where that DHEA comes from. If you go to the grocery store, you'll see it in the vitamin aisle. If you go to the GNC, you'll see it as a supplement. Those DHEAs very often do not contain a whole lot of actual active DHEA. And what is there is probably not easily processed in your body into anything resembling a high level. So most of these studies were done with pharmaceutical grade DHEA provided by the study group. And so that's very different from what you can sort of buy over the counter. What the studies showed was that DHEA-1 did not significantly improve a sense of well-being or health among women. And DHEA is thought to turn both into estrogen and testosterone, so it was used instead of hormone therapy, not with it. But they didn't find that it significantly improved health or well-being. It was unclear whether it affected menopausal symptoms because the trials were so inconsistent. And that may be partly from absorption and the quality of the DHEA, and it may be partly because some trials, if they don't use a placebo, there's a really nice placebo effect that we get with these types of symptoms. So, and what that means is if the placebo effect is if you give someone a sugar pill, about 20% of the time they'll feel better. That works even if you tell them it's a sugar pill, but it certainly works if you don't tell them. And so I think some of that confusion about whether it actually relieves hot flashes and things is because there's some placebo effect. It was found very mildly to improve sexual function. But again, a lot of these studies weren't well controlled, so there may be some element of placebo effect in there. And then finally, it was much more likely to have androgenic side effects. So those acne being the worst of them. But there was some hair growth as well. And I think the reason for that is probably because they had to use a lot more of it than we do when we're dosing testosterone, and I think they probably overdosed a bit. So that's my quick treatise on DHEA. I do not recommend it and I do not prescribe it. I just don't find that we have good data that it works, and we have other things that tend to work better. And it's no safer than any other type of hormone if it's truly turning into estrogen and testosterone in the body. So I don't think there's any benefit to be gained from it. So I rather use a hormone that I can understand the dosing of and feel more confident in where we are with it. The one thing I wanted to mention in this forum is that a lot of people are convinced to use or are selling hormones in pellet form. And I very clearly tell my patients that I do not believe in pellets. And the reason I do not believe in pellets is because they are very irregular in absorption. Depending on how deep they go into the body, you can absorb them quicker or slower. Women get very vastly different doses at different times from them. But most important, if you don't like the effects or they cause harm, if they start to cause hair growth from testosterone, or if you get estrogen or progesterone pellets and you start to have postmenopausal bleeding. I've had many women come to me and say, I need you to remove my pellets now. And I have to tell them that you can't remove them once they go in. because they're implanted deep and they're very tiny and you can't find them. They're not findable. So you are stuck with the effects of that pellet until it wears out, which is very irregular. So I never recommend these. They're also quite expensive and, in my mind, a bit of a moneymaker for folks. They're often offered at medi-spas by dermatologists or others who are not OBGYNs and don't necessarily totally understand the hormones. So I just tell women to stay away from those. In terms of prescriptions, someone asked, what do I prescribe? I have, the bulk of my practice is vaginal health and vaginal issues, so I tend to prescribe vaginal hormone primarily, whether that be estrogen or DHEA, which comes in a pharmaceutical grade for the vagina called Intrarosa, or a little bit of estrogen, testosterone, but I find the DHEA does a good job with that, so I don't have to do that as much anymore. In terms of systemic hormones, when I prescribe them, I tend to prescribe pharmaceutical bioidenticals. And that's a little different from what I think the layperson thinks of as a bioidentical. We think of a bioidentical as specially made just for me, like Suzanne Summers used to get. No one can actually make a hormone just for you, because they cannot measure your hormones and tell you what you need, because if you're in menopause, your hormones have gone down. If you're in perimenopause, they're all over the chart. So no one can match you. That is a myth of sorts. When people do compounded hormones, basically they're making a recipe up from the same bioidentical hormones that I would use in a pill form or in a patch form, and making a compounded cream which then becomes less regularly absorbed. So that's my personal take on the compounded hormones. I do use the bioidenticals, which is estradiol and progesterone, rather than conjugated estrogens and progestins, because I just find that women tolerate them better. I also tend to use transdermals primarily because I think, again, you get more even absorption and people just tend to tolerate those preparations better, but I'm also comfortable with oral preparations. I use progesterone only in women who have a uterus because that's very important for protecting the uterus from developing an endometrial cancer. If you give estrogen alone to women with a uterus, you can make endometrial cancer grow. So I'm getting a little note from our coordinator that Helen is trying to has her hand up or is trying to ask a question. Helen, if you pop up the chat box, which is at the bottom of your screen, and type it in there to me, I should be able to see it. In terms of progesterone and cancer risk, because that's the question I most often get asked, the place that comes from is from the Women's Health Initiative, which was published many years ago now and is the reason everybody came off hormones at that time. And what they did in that study was they took just tens of thousands of women and randomized them to start hormone or not start hormone, irregardless of where they actually were in menopause at that time. So some of these women are 10 or 15 years out from their menopause, but they were started according to their randomization. And the reason they did it, people say that seems like a crazy way to do it. Why would you start women on hormones 10 years out? Well, the reason they did it that way is because it was a study looking at cardiovascular health. And their thought was, even 10 years out, adding estrogen would protect women's hearts, because women tend to have fewer heart attacks before menopause than men do in those ages. Well, what they found was if you add progesterone and estrogen to a woman who's further out into menopause, they have a higher risk of breast cancer. The overall risk was still quite low, but it was over the group, higher than the group who took estrogen alone. When, I'm seeing a Q&A box. Oh. And Helen, I do see your question. I'll answer that next. When they sort of split the women in that study into the group that was closer to menopause and those that were further away, then the progesterone effect on breast cancer seemed to be much reduced, if not lost. And there's actually an active study going on right now with tens of thousands of women with the start of hormones immediately after menopause or during the perimenopause. But obviously this is going to take 10 or 15 years to result. So we just don't know what it shows yet, although I take comfort from the fact that they have not stopped it early due to cancer occurrences, which is what happened with the WHI. They actually stopped it before they were supposed to because they were finding that increased risk of cancer. So Helen wanted to talk about, is there anything available that's FDA approved for helping women who are distressed with their diminished libido? The answer is yes and no. There is testosterone. Addyi is approved for women premenopausally. It is not approved for postmenopausal women. So using that in someone who's postmenopause would be off-label and not within the FDA labeling guidelines. It doesn't mean we can't do it. Doctors use off-label medications and procedures all the time. It's just that we have to think a lot more hard with Addyi using it in a postmenopausal women. And the reason I mention that is that Addyi, when the studies were done, it took them 3 large-scale studies to show benefit. So the first 2 studies, which included about 900 women, did not show any increase in satisfying sexual desire encounters. They had to add another 1,500 women in their 3rd study to show an increase from 3 to 4 satisfying sexual encounters per month. And that doesn't necessarily mean intercourse. It just means any kind of fantasizing or masturbation or intercourse. The side effects of Addyi can be dizziness, fainting. There are several others, but the biggest issue was that these seem to be worsened by the combination of Addyi and alcohol. And so in order to take Addyi, you have to sign a contract that you will drink no alcohol while taking it. And in my experience, alcohol tends to be a pretty decent aphrodisiac for most women who are trying to increase their sexual desire, and in some ways better than Addyi. Now, if you're not a drinker, that may be less of a concern for you. Again, it's not that I would never prescribe it. I just don't find it to be a phenomenal medication. In fact, the only people I've ever encountered who really think it's great are people paid by the company to say that it's really great. I'd say the evidence for testosterone is better. And so I think that's a pathway you can go down. However, if you have a hormone-sensitive cancer, then it's a conversation that you need to have with your oncologist before you would consider starting it. But I think definitely if you can find a provider who's comfortable prescribing testosterone, then you could certainly give it a try, understanding the side effects of it. People often ask if there are alternative therapies that they can try. So I am in no way an expert on herbal remedies. And certainly we have an expert who works with us a lot of the time. Her name's Ariana Staruk, and she's from Bastyr University, where they teach naturopathic medicine, which is based on plants and foods and herbs. And she and I have discussed many times some of the sort of herbs that are safe to try to use in menopause to relieve symptoms. I don't know that there are any herbs or herbal preparations that are particularly good for sexual function or sexual drive. I certainly know that some women try the menopause herbs for sexual pain. I think they can be moderately helpful if the pain's not too bad. The one thing I always tell women is if you are having pain with intercourse, it will drive your desire down significantly. You're not going to want to do something that hurts. And so one of the very first things we always assess when someone comes in for decreased sexual desire is actually assess for sexual pain. Because if your tissues are hurting, then you're just not going to have desire. And that's not hypoactive desire disorder. That's just normal response to a painful stimulus. The reason I say that and the reason that's important is often we don't talk about that. We're supposed to enjoy sex. And when it's painful, it somehow seems shameful or embarrassing. It's neither of those things. First of all, it's a normal response to menopausal tissues. And it's fixable. It's something we can actually treat, either with vaginal hormone, vaginal lubricants, vaginal moisturizers. I also use laser for some women. And there are things we can do with physical therapy, and which sounds crazy, but there are phenomenal female pelvic physical therapists who work on helping women re-relax their pelvic floor when they're very tightly clenched and in pelvic floor pain from having either past trauma or current pain. And we can help most women have comfortable sex again. So seeing your OBGYN or talking to a physician with specialization in this is key to getting your sex life back. And I also tell women, as you move into menopause, oftentimes you've been with a partner for a very long time. And sometimes maybe it just gets a little stale. Or your desire is gone because there's a lot of built-up resentment. So don't discount psychosocial aspects of sexual desire. And if there are things that you need to work through, counseling can be very helpful. Sometimes sex therapy can be very helpful if there are things that you need to work through with your partner that are more sexual in nature. And sex therapists aren't scary and don't do weird things. They just really are talk therapists who focus on sexual function. And, I tell women sometimes vibrators, things like that. Bibliotherapy, reading sexy things can be very helpful to help stimulate desire. I have a question here about how long does one have to be on progesterone bioidentical compounded? So I do not use compounded bioidentical progesterone, and the reason I do not is because progesterone is a very large molecule and difficult to absorb through the skin. And so the only transdermal progesterone I ever use is the one that comes in a combo patch, and that's because it's been specifically formulated to be absorbed through the surface skin. The progesterone that they put in, so oral progesterone, okay, thanks for clarifying. So oral progesterone, you need to use it as long as you are using estrogen. And that is because estrogen causes growth of endometrial lining and progesterone stops that growth. And if you were to use only progesterone, you eventually will grow it into cancer. Now, if you're using very ultra-low dose vaginal estrogen, you don't need progesterone. But if you're taking an oral or a transdermal estrogen, then you absolutely need to use progesterone. You can do it any number of ways. You can take oral progesterone daily, sort of suppress the lining daily. Some women opt to take it once or twice a year and cause a menses to happen. And that's one way to sort of clear the lining of the uterus and protect it. We usually recommend doing it about every 3 to 4 months, but I've seen people do it slightly less frequently, maybe twice a year. Either of those are fine, but it does need to be done. The other option, and the one I know many OBGYNs take when they go into menopause, is to use Mirena IUD inside the uterus, which gives constant progesterone just to the uterus. So then you never have to take oral and you can just take your estrogen. I hope that answered your question. How long can women take testosterone? Well, that's a good question. We don't have long-term studies. The testosterone studies go out to about a year. Most of them, there are a couple outliers that go out as long as 24 months. Sorry, I'll answer the next question. I'm reading questions at the same time, so I get a little distracted. Sorry about that. There are a few studies that go out to 24 months. In my mind, I use it as long as it's needed. If you're doing well on it, you're not getting side effects, your cholesterol parameters are okay, then you can continue to take it as long as what you would take your hormone therapy. So for someone that's 5 to 7 years, but some women take it longer. It's just a matter of having that discussion with your physician about risk and benefit ratio. If it's really important to your quality of life and you're overall doing well on it without side effects, then it might be something you continue to take. Do I have a preference of progesterone? So I don't, you put up a couple of different names. I don't go by the brand names. I just prescribe progesterone instead of progestin. And those are just different formulations. So progesterone is the molecule. And off the top of my head, I can't remember which of those brand names that you placed up there is which. But I usually just write progesterone on my prescription. And they prescribe whichever one is on someone's formulary. And the only reason I do that is because women just seem to tolerate it slightly better. In birth control pills, we have many forms of progesterone, levonorgestrel, desonorgestrel. There's tons of different progesterones out there. But in the postmenopausal set, I just tend to use the simplest version of it. Are there any more questions? Actually, I'll qualify that last answer because when I talked about the Mirena IUD, that's actually levonorgestrel, which is a progestin. Or a synthetic progesterone. I'm not seeing any other questions. I'll give it one more minute, and then maybe we'll sort of do a quick sign off and talk about where we're going with Geneve. Well, while I wait for any more questions to come in, we're looking at the new year and deciding what we're going to do with these webinars, whether they'll continue. We're also, I don't know if you all know this, but Geneve is launching its Telehealth Initiative. So it'll start out in a few states to start. As we sort of get things going, we're going into beta tests in January. And then hopefully we'll build states where we have demand over time, and you'll be able to talk to providers like myself or some nurse practitioners over the internet and have 15-minute consults specifically about your issues. So keep an eye on that. Keep an eye on Geneve for that. And we will continue to be building the information on Geneve on the website. I think we just did an article on osteoporosis. And there are other great things that Shannon's putting out all the time. She's the writer behind all that great content. All right. Oh, and Shannon, there you go. Shannon just popped up. Oh yes, we have a YouTube channel. There you go. So definitely check that YouTube channel, and there's great information there. There's also great information on the website as well. All right. Well, I'm not seeing any other questions. It's been lovely chatting with everybody today. And I hope you got some good value for your time spent. If you have any questions that pop up later, you can always send them to that email that you got from Shannon before, and I'll try to get an answer back to you. But otherwise, I hope to see you in the future on Geneve platform. Thank you again for attending. Bye, everyone. How long can women take testosterone? Well, that's a good question. We don't have long-term studies. The testosterone studies go out to about a year. Most of them, there are a couple outliers that go out as long as 24 months. Sorry, I'll answer the next question. I'm reading questions at the same time, so I get a little distracted. Sorry about that. There are a few studies that go out to 24 months. In my mind, I use it as long as it's needed. If you're doing well on it, you're not getting side effects, your cholesterol parameters are okay, then you can continue to take it as long as what you would take your hormone therapy. So for someone that's 5 to 7 years, but someone would take it longer. It's just a matter of having that discussion with your physician about risk and benefit ratio. If it's really important to your quality of life and you're overall doing well on it without side effects, then it might be something you continue to take. Do I have a preference of progesterone? So I don't, you put up a couple of different names. I don't go by the brand names. I just prescribe progesterone instead of progestin. And those are just different formulations. So progesterone is the molecule. And off the top of my head, I can't remember which of those brand names that you placed up there is which. But I usually just write progesterone on my prescription. And they prescribe whichever one is on someone's formulary. And the only reason I do that is because women just seem to tolerate it slightly better. In birth control pills, we have many forms of progesterone, levonorgestrel, desonorgestrel. There's tons of different progesterones out there. But in the postmenopausal set, I just tend to use the simplest version of it. We're looking at the new year and deciding what we're going to do with these webinars, whether they'll continue. We're also, I don't know if you all know this, but Geneve is launching its Telehealth Initiative. So it'll start out in a few states to start. As we sort of get things going, we're going into beta tests in January. And then hopefully we'll build states where we have demand over time, and you'll be able to talk to providers like myself or some nurse practitioners over the internet and have 15-minute consults specifically about your issues. So keep an eye on that. Keep an eye on Geneve for that. And we will continue to be building the information on Geneve on the website. I think we just did an article on osteoporosis. And there are other great things that Shannon's putting out all the time. She's the writer behind all that great content. All right. Oh, and Shannon, there you go. Shannon just popped up. Oh yes, we have a YouTube channel. There you go. So definitely check that YouTube channel, and there's great information there. There's also great information on the website as well. All right. Well, I'm not seeing any other questions. It's been lovely chatting with everybody today. And I hope you got some good value for your time spent. If you have any questions that pop up later, you can always send them to that email that you got from Shannon before, and I'll try to get an answer back to you. But otherwise, I hope to see you in the future on Geneve platform. Thank you again for attending. Bye, everyone.